Okay.
Good evening, everybody. It takes me immense pleasure to invite you on to this NCSI classroom series. We have with us Dr. Nupur today, who will be speaking on the topic Dvt Prophylaxis in the Neuro ICU. And it takes me immense pleasure to introduce our moderator, who's also my teacher, Dr. Suparna Bharatwaj, who's from NIMHANS. Over to you, Nupur.
Uh, Good evening, everyone. Good evening, Suparna ma'am. Uh, I am Dr. Nupur, and I am an alumni of the NIMHANS Institute, and I'm presently working in Department of Neuroanesthesia at KIMS Bubhaneshwar. And today's topic of my presentation is deep venous thrombosis prophylaxis in neurointensive care unit. So once, uh, so Matangi, can I begin now?
Yeah, please carry on, Nupur.
Okay, so we'll begin with the presentation. So, coming to the introduction, deep venous thrombosis is the leading cause of preventable death in hospitals worldwide. The incidences of
The
DVT
incidences of
among
DVT among Nupur,
patients.
just make your screen full screen, please.
This is my full
This is
screen
my full
only.
screen only. Slideshow. Play the slideshow.
I am on the
I am on
slideshow.
the slideshow. Okay.
Okay, so the incidences of DVT among patients who are admitted primarily for neurological diagnosis is higher than patients who are being treated for general critical ailments. Incidences of DVT among our group of patients is around 18 to 50%, and management, treatment, as well as prophylaxis for
There is some technical glitch from Nupur's side. We're just trying to resolve it. 1 minute, please.
Everything's connected. Okay. Am I audible?
Yeah, you're audible.
Okay. I'm extremely sorry for the disconnection. I'll begin my presentation again. So today's topic is deep venous thromboprophylaxis in neurointensive care unit. So, DVT or deep venous thrombosis is the leading cause of preventable death in hospitals worldwide. The incidences of DVT in patients who are admitted and managed in neuro ICU, including both neurosurgical and neurological patients, the incidences is higher comparison to patients who are admitted and being treated for general critical ailments. Among neurocritical care patients, the DVT incidences ranges from around 18 to 50%. Now, prophylaxis as well as treatment of patients in neuro ICU is unique as well as challenging, as uh, the risk of hemorrhage versus the risk of thrombus embolism has to be balanced. So, thrombus on one hand, if left untreated, can embolize and can lead to life-threatening conditions. And on the other hand, the mainstay of their treatment is use of anticoagulants, which carries the risk of hemorrhage, which is particularly significant in neurosurgical patients. So, we deal with a very mixed group of patients. We have patients who are being managed conservatively. There are patients who are in need of urgent surgeries. We have post-surgery patients. We also have host of neuromedical patients as well. So the patient population in which we deal is quite heterogeneous, and a single statement of to start a particular kind of prophylaxis or to give a particular treatment for DVT will not help everyone. As a result, individual each patient's the biggest of various studies and literature on our set of population is that the definition of deep venous thrombosis is not standardized. Now, by per se the word deep venous thrombosis, we understand that any vein where any deep venous system which has a thrombus or a blood clot is labeled as deep venous thrombosis. But majority of the little different, as in our case it is not only the lower limb which can get affected, even the upper limb can also get affected. Is there any issue? So in our set of patients, it is not only lower limb paralysis, even monoparesis or hemiparesis can occur. They are more majorly focused on lower limb proximal veins. What happened? I what
You are audible, Nupur.
Okay, ma'am. I'll continue then.
No, but what is the problem? Are you unable to change slides?
I am able to change it from here, ma'am, but I got a call from Matangi telling that the signal is bad and I am not able
Yes,
to
there is
rectify
there
it.
is lot of interruption. Now it is better. You may continue. If it is bad, we will let you know. Maybe.
Okay, ma'am. So, like I was telling, that it is not only the lower limbs which we have to focus in our subset of patient, even the upper limb is at risk of developing thrombus, and there from there also embolism can occur, and it can be of significant morbidity and can cause significant morbidity and mortality to the patient. So when we sieve through multiple literature, we find that there are certain sets of studies which have taken these into consideration, that both upper limb and lower limb should be scanned, while in general it is only the lower limb which is focused more majority of the times. Now, coming to the pathogenesis of deep venous thrombosis, Rudolf Virchow had postulated that when three conditions, that is vessel injury, hypercoagulable state, and venous stasis, if all these three are present in the patient, then the chances, then clot formation occurs. And this has most prominently been seen in lower leg veins. Reasons being that the vessels or veins in the lower limb are larger, they have to move anti-gravity, hence the chances of stasis are more. Various conditions present in the patients like sepsis, complications of sepsis, hypertension, post-surgery like in our trauma patients, post-trauma, prolonged immobilization because of limb fracture, prolonged bed rest or prolonged intubation could be because of poor GCS or other factors, can lead to development of these three conditions in the patient, giving rise to thrombus formation and further consequences. Now, when we deal with these patients, it is not possible to allocate all the resources to every patient. Hence, for proper resource allocation, it is necessary to identify patients who are at higher risk of developing DVTs. So, multiple studies have been done to identify factors which can independently predict development of DVT in neuro patients. The risk, the number of factors can be seen. I have this in the present slide. Multiple factors can be seen, which are age, particularly female patient, age, higher age group, female patients, prolonged surgery time, history of venous thromboembolism, prolonged ICU stay, higher ASA physical status, blood transfusion, um, prolonged intubation, higher BMI, poor ambulation, hyperglycemia, hypertension, low all these factors have been shown to independently predict development of DVT in neuro ICU patients. So now these are independent factors. What about models, or what about the interaction of these factors with one another? So in order to develop a model, Parmenter et al. Had tried to develop a risk prediction model to predict the development of DVT. So he found out that non-Asian ethnicity has an odds ratio of around 6.11. Lack of post-operative ambulation has an odds ratio of around 9.25, and septic shock complication, presence of septic shock complication has an odds ratio of 5.36. If these three factors are present in a patient, then the chances of DVT development is quite high. Hence, these are the group of patients where we have to be more cautious. Now, once we have identified the risk factors of the patients, then what is to be done next? The next step is to be extremely cautious, be watchful of the clinical signs and symptoms, and regularly screen these patients, and to start the prophylaxis as early as possible. So the clinical features we are interested is swollen, tender, warm cough, venous dilatations, Hoffman in 50% of patients. These are relatively unreliable markers of DVT, and they are moderate ventilative or they are seen that in around 50 to 60% of patients, radiolabeled fibrinogen, which, when intravenously Yeah, what to do? I'm continuously connected here. Where should I begin from? Starting or okay? I'm extremely sorry for the disconnections happening. Uh, okay, I'll begin from the investigations. So, in the previous slide, I mentioned about various risk factors which are present in neuro ICU patients. Uh, which, if I, with the identification of these risk factors, we can label these patients as moderate or high risk for thrombus development. And then it is these moderate and high risk thrombus. It is these moderate and high risk patients where we have to be more cautious and watchful of their signs and symptoms, and we should be regularly screening these patients for thrombus development. Simultaneously, we should also start the mechanical or pharmacological thromboprophylaxis as early as possible for these patients. So, coming to the clinical features, we are a patient who develop DVT. They will have signs and symptoms of swollen, tender, warm cough, venous dilatation, a positive Hoffman sign. However, these signs are quite unreliable, and in around 50 to 60% of the patients, DVT patients who have developed DVT, these symptoms will not be present. Other investigations or screening tool which can be used is our radio labeled fibrinogen. So these radio labeled fibrinogen, when injected intravenously, will incorporate into the thrombus And once incorporated, when a scan is being done, these thrombus will be visible on the scans. However, this is not a very actively performed test. Another test which can be done is an impedance plethysmograph. So an impedance plethysmograph, it works on the principle that when a blood is flowing through an unobstructed vessel, the flow is relatively smooth and the electrical impedance the blood flow generates is quite low. However, same blood, when it flows through an obstructed or a blocked vessel, which has been blocked by a thrombus, the electrical impedance it will generate will be quite high. And this high electrical impedance can be identified by a plethysmograph. However, the problem with these tests is that false negative finding can occur in patients who have well developed collaterals. The most commonly used test or a screening tool is that of ultrasonographic examination of femoral veins. So it is not only the femoral veins which can be examined, but also the popliteal or the distal veins of the lower limb and the brachial and cephalic veins of the upper limb as well. So ultrasonography is a test which involves no radiation, can be does not involve radiation. The relative harm to the patient is less, and can be done repeatedly with and is not much time consuming. So in this case, high resolution linear probe is being used, and with the help of this probe, the vein of interest is being insonated, and many times a thrombus can be visualized just by scanning, or we can use a Doppler mode by which the flow can be assessed. If a thrombus is present, either there will be certain flow voids or there will be some sluggish flow. So if the flow is sluggish, the spectrum of the Doppler color spectrum will move towards blue. Other test which can be performed is compression test. So once we have scanned the vessels and we cannot find any visible thrombus, firm pressure with the probe can be applied to see whether the vein can be compressed or not. Non-compression of a vein indicates that the vein is filled with clot. This is a highly sensitive and specific test, and the sensitivity specificity range is more than 90%. However, it requires presence of an ultrasonic machine, and also requires certain level of training to properly identify and diagnose DVT. Definitive diagnostic test is that of venography. So venography makes use of fluoroscopy as well as contrast dye. So in this, a contrast dye is being injected and the fluoroscopy is being run to identify the veins. So once the vein is being identified, if any thrombus is present, it will be visualized as flow voids in the scan. The problem with these tests is that there is a risk of radiation exposure. There are complications associated with contrast dye injection, and also they are time taking. Hence, these are not routinely used as a screening measure. Now, after as spoken earlier, also that we have to also start mechanical or pharmacological prophylaxis as early as possible in patients who are at high risk of DVT development. So, most commonly and readily available mechanical prophylaxis measure is that of graduated compression stocking. So, these stockings are designed in such a way that they create a pressure gradient from the ankle to the thigh. So various kinds of stockings are available. Some are up to the knee level, some are up to the thigh level. Studies have shown that thigh level stockings will perform better. Also, there are various class 1, 2, 3, depending upon the severity of illness. So these stockings were initially developed for treating varicose veins. So the classification is also on the basis of severity of varicose vein being treated. For mechanical prophylaxis, a class 1 or a class 2 graduated compression stocking is considered good enough. So the pressure gradient is generated such that at the ankle the pressure is highest, and then at the knee and the thigh the pressure is comparatively less. Usually the difference is of around 10 mm Hg, and this pressure gradient helps in forward or upward movement of the blood in the venous symptom. This is one of the most easiest prophylactic measure that can be used. However, this cannot be used as a solo measure for high risk cases. The another mechanical prophylaxis available is intermittent pneumatic calf compression. So this has a sleeve which is wrapped around patient's calf, and then the sleeve is connected to a pump. Now the pump has a program in so that it can inflate and deflate. So the program ensures that the pump will inflate and deflate the sleeves at a regular interval. This regular inflation and deflation gives a pumping action. It generates a pumping action, and this augments the venous blood flow. This is the preferred measure in neurosurgery patients where anticoagulants have to be avoided. Now, coming to the pharmacological prophylaxis, unfractionated heparin at low dose was the amongst the first pharmacological agents being used for DVT prophylaxis. So, as known, heparin is an anticoagulant. However, the dose which we use for prophylaxis is very low and full anticoagulation is not achieved. But the rationale is that at small doses of heparin, it will inhibit the thrombus formation. The dose usually recommended is 5,000 units subcutaneous 2 to 3 times a day. The advantage of using heparin is that it is easily reversible and it is safe in renal disorders as well. The disadvantage is that heparin can cause thrombocytopenia. So, though in neurosurgery and neurocritical care guidelines, much is not mentioned about heparin-induced side effects, but in regional anesthesia guidelines, it is recommended that if heparin is being used for more than 4 or 5 days, a regular platelet count should be done as to rule out thrombocytopenia. Then the other agent available is lower molecular weight heparin. These lower molecular weight heparin are a smaller molecules in comparison to heparin and have shown to be more potent and are more predictable in their anticoagulant effect than unfractionated heparin. These do not require anticoagulant monitoring, and at present it is uh, more preferred than unfractionated heparin among intensivists. Two most commonly used drugs are enoxaparin, which is 40 mg subcutaneous once a day for moderate risk patients, and 40 mg twice a day for high risk patients. Dalteparin can be given at a dose of 2,500 units once a day for moderate risk patients and 5,000 units once a day for high risk patients. The advantage of lower molecular weight heparin over conventional heparin is that the dosing is infrequent. Heparin-induced thrombocytopenia incidences are much less, and also the risk of bleeding is much less with LMWH. Other pharmacological agents. Am I audible still?
Yes, Nupur.
Ma'am, are the slides moving?
Yes, yeah.
Okay, then I'll continue now. Okay, so now I have already spoken about heparin and LMWH. Now, other agents which can be used are warfarin. Warfarin has not shown to have any added advantage in neurosurgery patients over LMWH and is not routinely seen in neuropractice. But however, it is possible that you have patients who have concomitant orthopedic injuries or fractures as well. And in that case, you might come across a orthopedician who is recommending warfarin for long-term management of his patients. So when warfarin is being given, the targeted INR is around 2 to 3. And if the patient is posted for surgery while on warfarin therapy, it has to be stopped at least 4 days in advance, and a bridging therapy with LMWH has to be done. And good part about warfarin is that it can also be reversed with the help of fresh frozen plasma or prothrombin complex concentrate. Fondaparinux is a newer oral anticoagulant. It inhibits factor 10A and has a predictable anticoagulant effect. And the prophylactic dose is around 2.5 mg once a day subcutaneously. It does not cause thrombocytopenia. However, it is contraindicated in patients with renal disease or in patients with less than 50 kg weight. Dabigatran is also one of the newer oral anticoagulants available, and it acts by inhibiting thrombin. It is a direct thrombin inhibitor and has a rapid onset action. It can be given orally at a dose of around 110 mg twice a day, and it has shown to be quite useful for acute DVT patients, and for patients posted for surgery, it has to be stopped at least 48 to 72 hours prior to surgery. So now we have come across the various patients who are at high risk of DVT development, various prophylactic measures that can be given to these patients. However, as said earlier, that the patients which we deal with are quite heterogeneous. There are patients and they are quite heterogeneous, and with so many hosts of strategies available, it becomes quite confusing as to which agent should be started first and which agent can be like not given or is harmful for the patient. So in order to clear the confusions, Neurocritical Care Society came up with a guideline for prophylaxis of venous thrombosis in neurocritical care patients, which is an evidence-based guideline in the year 2015. So what they did in these guidelines was they divided the patients depending upon the pathology. So we'll discuss about each and every patient as the presentation continues. So first I'll talk about post craniotomy patients. So among craniotomy patients, presence of malignancy, cerebral metastasis, glioma patients who have shown to have higher risk of DVT development, prolonged surgical duration, and presence of neuroinflammatory reaction. These factors have shown to risk increase the risk of DVT in DVT development. The rate among these patients ranges around 2.6 to 14%. Pneumatic compression stockings are the preferred mechanical prophylaxis in these patients. However, it has been shown that these patients patients, especially who can verbalize, they find this to be very cumbersome and it is not very well tolerated. In certain places where you practice, you will also come across support staff and healthcare workers who are actually not aware about pneumatic compression devices and how they work. Uh, Coming to pharmacological thromboprophylaxis, both LMWH and unfractionated heparin have not shown to increase any intracranial bleeding risk. The guideline recommends that intermittent pneumatic compression with either LMWH or unfractionated heparin should be initiated within 24 hours after craniotomy. Even in patients where they are undergoing glioma resection, same recommendation uh, should be followed. That is, pneumatic compression with low molecular weight heparin or unfractionated heparin should be given within 24 hours. This thromboprophylaxis is being advised to be continued till discharge of the patient. Now, for patients who are on brain tumors but have not undergone surgery, malignant glioma patients, they are at higher risk of developing DVT. The incidences of venous thromboembolism is around 20 to 30%, and it is recommended that pharmacological prophylaxis in the form of LNWH or unfractionated should be given to these patients as early as possible. So as soon as these patients are hospitalized, the pharmacological prophylaxis should be started. However, they have also cautioned that use of these anticoagulants will carry the risk of hemorrhagic conversion. Hence, a clear discussion with neurosurgeon has to be done before starting these agents. Now, coming to elective spine surgery, the incidences of DVT among elective cases is
Your slides are not changing in case you wanted to change.
I
We couldn't see the slides for the brain tumors actually.
uh,
Yeah.
even now
Now,
it's not.
yes, now you have
It's
come to brain tumors. Yeah, you can move on, but I just wanted to tell you slides were not changing. You can go to the spine section.
Okay. So now coming to elective spine surgery, patients who
You
are
are on
undergoing
the tumor slide now.
now is it on spine surgery slide?
No, not yet.
Is it?
Yes, now we can see.
Okay. So the risk of DVT development in patients undergoing elective spine surgery is quite low. It is around 0.7%. But the major issue with these patients are that 50% of them will not have any manifestation, that is clinical signs and symptoms of DVT up till discharge. And the fear of epidural hematoma with the epidural hematoma formation with pharmacological prophylaxis has been shown to be an unfounded fear. The guideline they recommend that in elective spine surgeries where a patient can be ambulized early, mechanical prophylaxis and early ambulation is good enough, and it may or may not be combined with lower molecular weight heparin. Then patients who are at increased risk of venous thromboembolism, they recommend that a combination therapy along with ambulation has to be has to be started for the patients. They also recommended that unfractionated heparin should be used only as an alternative. So, saying that mechanical prophylaxis in the form of compression stocking or pneumatic compression and LMWH are the mainstay for patients undergoing spine surgery with increased risk of VT. Unfractionated should be used only if we don't have LMWH available. Now, for complicated spine surgery, the society recommended that pneumatic compression devices with lower molecular weight heparin or unfractionated heparin should be used. For spine surgeries who do not have a DVT in situ, routine use of IVC filters are not advised. And if we come across patients who have pulmonary embolism or who have DVT, in such cases, a removable prophylactic IVC filter can be used as a temporary measure. For patients who are being managed for spinal cord injury, DVT incidences have been shown to be very high. Untreated patient, the incidence reported is in the range of 18 to 100%. This risk is highest during the first 2 weeks after injury, and then it gradually decreases after the first 3 months, and then it further decreases after 6 months. The society recommends that prophylaxis, mechanical or pharmacological, should be started as early as possible and preferably within 72 hours of injury. Uh, uh, Lower molecular weight heparin or low doses of unfractionated heparin should be initiated as soon as the bleeding is under control. And they suggested that mechanical prophylaxis with pneumatic compression should be used when pharmacological prophylaxis is contraindicated. And mechanical prophylaxis should not be the only prophylactic measures used for these patients. So, though we can start with a mechanical agent as early as possible, but as soon as the bleeding complication or the bleeder has been controlled or the patient has stabilized, in such cases, pharmacological agents like lower molecular weight heparin should be started. Now, in aneurysmal subarachnoid hemorrhage patients, DVT incidence is around 1.5 to 2.4%. And the society recommends that in all aneurysmal SAH patients where the aneurysm has been clipped or coiled, in such cases, the unfractionated heparin should be started. Now, one particular thing to note here is that in all other previous patient subgroup, it was lower molecular weight heparin was recommended. But here it is the unfractionated heparin which is being recommended. This being that they have found in various studies that with LMWA, the incidences of hemorrhagic transformation in aneurysmal SAH is higher, and hence they recommend unfractionated heparin in this subgroup of patients. For pneumatic compression, they have advised that it should be started as soon as possible or as soon as the patient is admitted in the hospital. And if unfractionated heparin has to be started in patients who have undergone surgical coiling or clipping, then in such cases, it should be started at least within 24 hours of surgery. Then coming to ischemic stroke, the incidences here is highly variable. That is, the reported incidence ranges from around 10 to 75%. Known risk factors are old age, female sex, hemiparesis, high NIHS score, and usage of intraarterial tissue plasminogen activator. Uh, as per the recommendations, uh, they recommend that pharmacological prophylaxis should be started in all should be started in all feasible patients of acute ischemic stroke, patients who are immobilized or have restricted mobility. In such cases, lower molecular weight heparin should be started with intermittent pneumatic compression devices. These pharmacological prophylaxis should be continued for at least 2 weeks. And in patients who have undergone surgery or who have undergone endovascular procedures, in these patients also, unfractionated heparin or lower molecular weight heparin should be started with or without an pneumatic compression device. One point to note is that if they have undergone endovascular procedure or if they have undergone tissue plasminogen activator therapy, in those cases, the pharmacological methods have to be delayed for 24 hours. For use of mechanical prophylaxis, they recommend pneumatic compression device over graded compression stockings. For neuroendovascular procedures, patients without hemiparesis, that is, patients who are undergoing elective procedure, early ambulation is advised with or without mechanical thromboprophylaxis. Use of lower molecular weight heparin or unfractionated heparin is not needed in these group of patients. Patients who have hemiparesis, in these cases, pharmacoprophylaxis with without mechanical prophylaxis can be initiated within 24 hours of treatment. And it is advised that activated thrombin time should be measured regularly in these patients. If tissue plasminogen activator has been used, then the chemoprophylaxis should be delayed for at least 24 hours. For traumatic brain injury, the incidences reported in literature is around 54%. Brain Trauma Foundation in their fourth edition recommended that lower molecular weight heparin along with mechanical prophylaxis should be started as early as possible. However, they also highlighted the risk of intracranial hematoma expansion with the use of pharmacoprophylaxis. The Neurocritical Care Society guidelines recommend that intermittent pneumatic compression should be started within 24 hours of traumatic brain injury or within 24 hours of craniotomy. And pharmacoprophylaxis in the form of lower molecular weight heparin or unfractionated heparin should be initiated within 24 to 48 hours after TBI or or 24 hours after craniotomy. They have also warned that pharmacoprophylaxis should be initiated only when the benefit of use of these therapy outweighs the risk of intracranial hemorrhage. For ICH, the incidence of DVT is around 1 to 5%, and the recommendations are that mechanical thromboprophylaxis should be started at hospital admission if the hematoma has stabilized and if there is no ongoing coagulopathy. In such cases, unfractionated heparin or lower molecular weight heparin can be initiated, and preferably the time to initiate this is at around 48 hours of hospital admission. In neuromuscular disorders, uh, particularly in Guillain-Barré syndrome, the incidence of DVT is around 4 to 7%. Prolonged immobility long stay in ICU units, and respiratory failures are known risk factors. Uh, Pharmacoprophylaxis are the preferred agents for prophylaxis. And in case pharmacoprophylaxis, pharmacological agents are contraindicated because of increased risk of bleeding. In such cases, intermittent pneumatic compression devices can be used. A combination of pharmacological and mechanical prophylaxis can be used whenever possible. Also, for the duration of VT prophylaxis, they have told that these prophylaxis should be continued as long as the patient is in hospital or till the patient is able to ambulate. Now, we have discussed about various subgroups of patient which we deal with, but a particular subgroup which we come across on day-to-day practice is not being mentioned in these guidelines. That is patients who are managed with external ventricular drain. Now, external ventricular drain is an invasive catheter into the intraventricular system. And what I have seen in my experience is that neurosurgeons in my hospital are quite reluctant in starting chemoprophylaxis or pharmacological prophylaxis in these patients. So this snipe is being taken from an article which was presented in International Stroke Conference, and in this study, it is a retrospective study where they have evaluated 99 patients, and they have found out that in 99, roughly 50% of the patient, the pharmacological prophylaxis was started within 24 hours of EVD insertion, and in another 50% of the patients, EVD pharmacoprophylaxis was started after 24 or after 48 hours of EVD insertion. So in this study, what they have found out that incidences of hemorrhagic complications with starting of chemoprophylaxis within 24 hours of EVD placement was not high. So this was though a retrospective study. This study just gives an idea that starting DVT prophylaxis or anticoagulants in EVD patients early might not be harmful. Now, another problem which we come across in patient while dealing with patients with EVD is that as to when to at how to time the EVD removal. So, though in Neuro Society guidelines, there are not much has been mentioned about how when should we remove the EVD drain with respect to anticoagulation therapy. But what we follow here is we follow the American Society of Regional Anesthesia guidelines. So ASRA guidelines have spoken extensively about anticoagulants and regional or neuraxial blockade. And in our setup, we use lower molecular weight heparin on a regular basis. And once the EVD removal is planned, at least 12 hours prior, we will stop the lower molecular weight therapy and then start at least 4 hours after EVD drain is being removed. Now, once these are the strategies uh, which are being in place to prevent thrombus development. But once the thrombus once the thrombus is formed in the patient, then what to do next?
Your
So
slides
these
are not moving again. You are still in spine surgery, actually. Probably you have to change on the side. No, you have gone back.
spine surgery. I absolutely have
Yes,
no idea why.
actually, you have moved on, but I didn't want to interrupt you. Come down, yeah.
Can you see, ma'am, the life cycle of a thrombus?
Yes, Nupur.
Okay. So, uh, till Mm. Am I audible?
Yes, you are.
Okay. So till now, I've spoken about the patients who are at high risk of developing DVT. What are the strategies which can be implemented to prevent DVT from developing? But even after doing our best, not every patient, uh, not in every patient, DVT development can be stopped. And once the thrombus have is in place, then we have to deal with either treating the patient or preventing further complications from developing. So now these thrombus can either undergo a complete or partial resolution, they can undergo clot extension and embolization, or they can organize. So by complete or partial resolution, I meant that the fibrinolytic system which is in place in a human body, they act and they lead to either complete or partial dissolution of the thrombus. The other scenario is that where a clot, it goes on developing, it progresses, and then ultimately it embolizes and it reaches the distant organs. This is a life-threatening situation, and patients with embolization can present with sudden cardiovascular collapse as well. By organization, what was meant was that inflammatory cells, they will infiltrate the thrombus, and this will lead to remodeling and clot getting incorporated into the vessel wall, and and then ultimately leading to re-endothelialization. So, with this re-endothelialization, what happens is the clot, though it gets incorporated into the wall, the vessel, they become somewhat patent, but the vessels, they are scarred. So the valves are damaged, the vessel walls are damaged, and this leads to development of post-thrombotic syndrome in patients. So these patients, they have to deal with pain, leg edema, and signs of venous insufficiencies. This is seen in roughly 33% of patients with DVT. Now, coming to thromboembolism, as I said, it can lead to life-threatening symptoms, and this can be identified with development of sudden hypoxia or hypocapnia in patients. In ECG, we can see sinus tachycardia, P pulmonar, right axis deviation, atrial fibrillation, S1Q1 T1 pattern. While doing a Doppler examination, we'll identify that there is a venous thrombus in the lower limb proximal veins. In transthoracic echo, there might be RARV dilatation and right heart failure. In ventilation perfusion scan, there will be mismatching. The gold standard for diagnosis is a pulmonary angiography, where we will see flow voids in the pulmonary vessels. So the treatment of thromboembolism consists of anticoagulants, that is unfractionated heparin, but at a much higher dose. So in these situations, it is administered intravenously. A bolus of around 80 units per kg, followed by a continuous infusion of 18 units per kg per hour is being given. APTT is checked at a regular interval of 6 hours, and the target APTT is around 46 to 70 seconds. Lower molecular weight heparin can be given at a dose of around 1 mg per kg for enoxaparin subcutaneously and has to be given at a twice daily dose. There is no need for monitoring anticoagulation in patients treated with LNWH. Warfarin therapy is usually started along with heparin therapy, but we have the warfarin therapy has to be washed carefully, and once the INR has reached 3, then the heparin can be discontinued. It is shown to be useful in neurological conditions but is not routinely used in neurosurgical cases. For life-threatening pulmonary embolism cases, thrombolysis can be uh, done. Alteplase can be used at a dose of 0.6 mg per kg and can be given over 15 minutes. Retaplase can be given for 10 units by bolus injection, and it can be repeated in 30 minutes. Its use in neurosurgery is limited, as thrombolytic therapy is associated with risk of hemorrhagic conversion. Inferior vena cava filters can be used in patients who have pulmonary embolism but are in a stable condition. In neurocritical care patient, it is not used when there is a contraindication to anticoagulation therapy. Pulmonary embolectomy can be done in hemodynamically unstable patients in whom thrombolytic therapy is contraindicated. In these cases, the emboli are removed surgically or by an endovascular technique. So, my conclusion to this presentation is that mechanical prophylaxis should always be initiated and used as early as possible in any neuro patient. Pharmacological prophylaxis must be considered and discussed with the neurosurgeon and should be initiated once indicated and once it is safe and beneficial for the patient. The guideline which was discussed in this presentations, they come with a strong and a weak recommendation, and depending upon the grade of recommendation and what is best for the patient, the prophylaxis should be initiated. Thank you.
Thank you, Nupur. You have covered the presentation extensively. I had two questions for you. One is, can pneumatic compression device replace the pharmacological protection that you mentioned? So, if I do not want to use pharmacological protection for fear of hemorrhagic transformation, for example, in stroke, or if there is large hematoma sitting in the head, secondary to ICH, can I use only pneumatic compression? What does the recommendation say?
Should be initiated. Pharmacology should be delayed, but as we ensure solely we have
Since we have lost Nupur now, to continue with this discussion, ma'am, Nupur is back. Yeah, Nupur, go ahead. Yeah. Go ahead.
So what I was telling is that in stroke patients where there is a fear of hematoma expansion or hemorrhagic conversion, initially it is okay to start with a pneumatic compression device, but at some point we will have to start a pharmacological prophylaxis. These patients will not be at risk of hemorrhagic conversion throughout their disease course. At some point the disease will stabilize, and in those at that moment we'll have to introduce the pharmacological agents.
So the mechanical thromboprophylaxis does not replace pharmacological thromboprophylaxis.
Yes,
So
ma'am. It does not replace.
that's the recommendation. And the second question is, are you really compliant with these guidelines? Because I, at least in NIMHANS, probably you know that for every patient, the procedure is to ask the neurology or the neurosurgery team before you confidently start thromboprophylaxis for these kind of cases. Say patient with ICH having a large hematoma, so you don't confidently start the thromboprophylaxis at 72 hours as per recommendation. So, are you compliant? One example you yourself quoted regarding EVD. So, the neurosurgeons are not comfortable starting on thromboprophylaxis in the presence of EVD. So, are we compliant? Because I see some of the studies just looking at the compliance of these thromboprophylaxis guidelines. So, what is your experience?
Ma'am, as a person practicing neuro ICU, I cannot be the only decision maker for the patients. There are neurologists as well as neurosurgeons who are taking care of the patient. And whenever there is such a situation where the patient is at risk, like if I start a pharmacoprocollegial agent, there is a risk that there will be hematoma expansion or patient has chance of deteriorating. In such cases, we discuss with the neurosurgeon. We explain to them that this is our concern, that EVD is in C2 and patient has hemiparesis, and if we don't start DVT prophylaxis, patients' thrombus can get worsen or those things. And then once the neurosurgeons are comfortable, we initiate the therapy. One thing which I have done in our setup is like after EVD insertion, there will be a CT scan. In that CT, if there is no obvious hematoma intracranially at the site of EVD insertion or through the EVD tract, I at least coax my surgeon to at least start unfractionated heparin. Just giving the reason that unfractionated heparin can be easily reversed, and if there is any hemorrhagic conversion, we can at least like use protamine and reverse it. So this is what I try to do from my side.
In one of the ICUs where I recently worked, the practice is to have the CT scans done at a particular time interval. For example, for patients with ICH at about 72 hours, again, patients with brain trauma 48 to 72 hours, you determine that there is no new hematoma or the expansion of the hematoma compared to the baseline, and then start the anticoagulation. And then again, there will be an interval CT scan after about 48 to 72 hours. So, this is a routine exercise that some of the hospitals follow.
One more is the bleeds related to anticoagulants, especially with apexaban. The hematoma expansion is little bit later, more than 72 hours. So in that case, how do we go about initiating DVT prophylaxis in these patients?
I mean, apixaban straight away. I mean, you go with
Patients coming with an bleed due to apexaban, ICH due to apexaban, the newer DOACs.
so
Those
those, I
patients,
think,
the hematoma expansion is little bit later. So the 72-hour scan might still show a normal, no hematoma expansion and stable bleed, but they might expand a little bit later. So this is something which we have been noticing in cardiac patients on apexaban who come with an ICH.
but
So
if
in
I
that
can
case,
the guideline mentions about patients having apixaban, and I think it should be started in a delayed manner. You should withhold the, of course, apixaban, and when you start also low molecular weight heparin, it has to be delayed. I think I came across this guideline.
so in that case, probably a delayed scan rather than 72 hours. Apexaban expansion maximum is at 5 days after we stop. So maybe a delayed scan to ensure that there is no hematoma expansion, and then DVT prophylaxis can be
Yes.
initiated.
Yes. Any questions from the
Yeah. One question was this apexaban, which we have discussed. Next is how long to continue DVT prophylaxis?
For neuromuscular disorders, they say that it has to be continued till the patients are in the active phase of the disease and till the patient can be ambulated. For neurosurgical patients, not neurosurgical, for traumatic brain injury, it is told that it is to be continued at least for 2 weeks.
So, do you
Is
mean
there
if they having weakness, you can discontinue thromboprophylaxis?
Ma'am, the best would be to assess the risk factors at that moment before discontinuing the pharmacological prophylaxis, to reassess the patient to see whether the risk factors have reduced or not, and then to take a decision. If the patient has ongoing sepsis, septic complications, and he has other risk factors also, in those cases, discontinuing might not be correct.
Another question is there any objective risk stratification to determine thromboprophylaxis?
Objective risk activation, there is a Wells criteria which has been designed for outpatients and has been validated in inpatients also, certain sets of inpatients. But per se, for neuro, there is no separate criteria or model which has been developed. But Wells criteria is what which I had used previously when I was doing my DM, and I also try to implement it here when I'm working.
How to improve compliance to DVT prophylaxis practice?
One way, the problems which I had faced when I was working here was that leave the physicians, even the sisters, they are not aware of how these mechanical prophylaxis work and what is the importance of use of these agents. So what we did from our side was we conducted regular classes, like every 10 days we used to conduct classes, that so that they know the importance of stockings and pneumatic compression devices. And other thing was, whenever we are doing morning rounds, we have a separate checklist in for every morning rounds, where we will see that okay, the compression stock is on the patient, pneumatic compression device is on the patients, and at 24 hours we'll also see whether we are able to start the chemoprophylaxis or not. For neurologist and neurologist and neurosurgical patients, neurosurgeons, what we try to do is whenever they come for down, we interact with them and make them aware of what the recent guidelines are or what is going on in the academic world, so that they become aware and they also become like compliant to it.
Ma'am, your comment on this?
I agree with Nupur, and again, even though guidelines are there, every individual case may be different. So it's always we cannot blindly stick to the guideline. Of course, guidelines are recommendations. So you assess the patient at that particular duration, whatever is recommended, and then interdepartmental discussions are always important. You yourself quoted an example of apixaban, so where you can't blindly stick to the guideline of 72 hours and harm the patient. So it should be rationalized.
No further questions, ma'am. I take this opportunity to thank Suparna ma'am and Nupur for being part of this NCSI initiative of Classroom. Thanks for this wonderful talk.
Thank you.
Thank you, ma'am.